Welcome to everyone. This is our series of presentations on transplantation of the Group Florence Nightingale Hospitals. And I will be responsible for the presentation of the autologous stem cell transplantation in COVID-19 era. My presentation will cover, first of all, the current situation in autologous stem cell transplantation and role. What's the current status in Europe and States? A few indications, and then our experience and the comparative analysis with Europe and USA. As you know, the high-dose chemotherapy definition is not limitless. We always say we have to give as high as possible, but first of all, we should always avoid an unacceptable extramedullary toxicity, which mean a renal dysfunction, which can go to a renal failure, an acute one, and which can proceed to a chronic renal failure. Gastrointestinal, in heavy cases, we see intestinal and gastric hemorrhages, and then hepatic dysfunction with cholestasis and sometimes hepatic failure. This should be the situation that we should avoid in all instances. And coming to neurological dysfunction, this is the most important thing. Both, it can be only a slight peripheral neuropathy, but then in severe cases, we can have encephalopathies or acute brain injury. Coming to medullary toxicity, this is reversible, but we should always be very careful to avoid a permanent damage, not to the medullary side, but to the infrastructure of the bone, which can also go to an allogenic transplant rescue. High-dose chemotherapy in current conditions are very straightforward, and in autologous setting, there is not much actually discussion about which conditioning regimen has to be used. Why we are using a high-dose chemotherapy? This is a very simple question, but unfortunately in referral patients, we always see that this question is not quite answered. Why? If you have a patient who did not respond to chemo 1 or did response but recur very easily or untimely, then we are using a double strand of the chemotherapy, which we are calling a salvage chemotherapy. After salvage chemotherapy, if there is a sensitivity, then we go further to a high-dose chemotherapy, which means if you prove the chemosensitivity of your underlying disorder, it can be a lymphoma or any kind of chemosensitive solid tumor as well. You know our indications in germ cell tumors and in some other germ layer malignancies, the high-dose chemotherapy then is indicated. But if it's not with chemotherapy salvageable, there is no shown chemosensitivity, then we should not go to high-dose chemotherapy. There's only one indication which we are currently still using in chemorefractory, the autologous and high-dose chemotherapy, but in current conditions, actually now less, because we have many new monoclonal antibodies and agents. This is the Hodgkin's disease. In Hodgkin's disease, the refractory patients are also profiting well with high-dose chemotherapy, but with the actually introduction of anti-CD30 antibodies and then the novel immunotherapies with nivolumab, it looks like that we will certainly do these high-dose chemotherapies less. And if we summarize the procedure of the high-dose chemotherapy. As you know, for lymphomas and myelomas, nearly 90 to 95% of the indications, we first of all collect the autologous stem cells, cryopreserve them. This is the first step. Then we have low disease and we have cryopreserved autologous stem cells. On the second, we hospitalize the patient and then we utilize high-dose chemotherapy accordingly to the underlying condition. In myeloma, it's high-dose melphalan, still standard 200 milligrams per square meter. In lymphoma patients, there's an ongoing debate, but beam skeleton still looks like the standard, but BCNU can be exchanged with Thiotepa, a team, or with Carmusim or BC. This can be actually changed, and there are recent reports that with all of the agents, the transplant outcome is more or less is the same. And then after the effect of the chemotherapy is over, means we rest for 2 days, and then we thaw the cryopreserved stem cells and infuse them. Then after 2 weeks of an aplasia, the cells come over, the patient is engrafted. We can encounter with some infections. We should be careful about conditioning regimen related toxicities. And after recovery, after 2 or 3 months, we check for the underlying disease. If we come up, what's the current condition, both in Turkey and Europe? As you see, Turkey has improved in recent years very much, and now nearly the transplant rate in our country and in both Western and the Eastern Europe is nearly the same. And coming to conditions, they are nearly identical. More than half are then myeloma patients, and then followed by the lymphoma patients. Non-Hodgkin's lymphoma in the second, and Hodgkin's lymphoma are on the third row. Then a few AML cases, both in Europe and Turkey, and which is actually more or less in low-risk patients with low-risk favorable cytogenetics and in recurring M3 patients. And if you look the conditions in states, we'll see the same tendency. First of all, myeloma, followed by non-Hodgkin's disease, lymphoma, and then the Hodgkin's disease. And if we look the trend, you see there is a drop in the trend for non-Hodgkin's and Hodgkin's lymphoma, which is apparently, first of all, we will see on the upcoming slides due to CAR T-cell therapy. The new CAR T-cell therapy options in Turkey, in states, which is now FDA approved, looks like that they've changed the scenario, and then less patients are now referred for autologous transplants in states, nearly half of the cases. And if you looked at the toxicity before day 100 and after day 100, obviously before day 100, we have still in refractory cases in 1/3 the recurrent, or actually I will refer refractory disease. You can't get rid of. This is primary refractory disease. Then it can be followed by the infections and the conditioning regimen related toxicities. If we come up on the long-term sequela, then we will see that nearly in 80% of the patients, the disease relapse, the recurrence is the first problem which causing death or transplanted patients. And if we come over our transplant total activity in our Florence Nightingale Hospitals, you see that now we have, in the start of 2019, we have actually accomplished to have the 1,000 transplants beyond us after 10 years. And now we have reached actually 1,200 transplants nearly, and more than half are autologous transplants. And if we look to the indications, this diagram is nearly identical with Europe and with states. As you see, plasma cell disorders, mainly myelomas followed by amyloidosis and Poem syndrome, and on lymphomas, mainly non-Hodgkin's lymphomas and followed by Hodgkin's disease, and a few multiple sclerosis patients in selected patients allowed with official permission in Turkey, and the low-risk AMLs. And if we come to overall survival, that's not a recent, but we have shared in the third COHEM Congress. You see the procedure is still both on the early days, safe, and looks like acceptable. If we look to the first step, the collection, how we collect the stem cells, this is more or less standardized, which means you can collect your cells with only GCSF, with after disease-specific chemotherapy, or you can use a mobilization chemotherapy and GCSF. In both settings, you can do the stem cell transplantation. But currently in COVID-19 era, we are always trying to get rid of hospitalization and to do everything on outpatient basis. And so we always underline that GCSF only, maybe especially in myeloma patients, the actual mobilization methodology. But if we are failing, then if we are a lymphoma patient, then we can go on with disease-specific chemotherapy or mobilization. Then use of plerixafor is another issue. And if we look to the myeloma and the lymphomas, we are almost always referring to the peripheral CD34 counts before transplant. And according to this, we have good mobilizers, we have in gray zone, and we have poor mobilizers. In poor mobilizers patient, we should use the plerixafor to get rid of the more hospitalization, to get rid of more mobilization regimen used chemotherapy. And our aim is always 2 to 3 times 10 to the 6 CD30 positive cells collected. This is still accepted for one transplant. In myeloma patients, we are aiming that we should have more than 10 to the 6 million cells per kilogram. This is one of our studies that we have shared in MVMT 2016. As you know, with the peripheral blood stem cells and your collected cells are nearly identical, directly correlated. And if you are going to collect your peripheral blood stem cells, you should rely only on the reliable peripheral CD34 positive counts. And if we go to our experience and to the what's going on in the myeloma setting in autologous stem cell transplantation, you will see since 1980s, we are actually able to do the autologous transplant. The high-dose melphalan was introduced in the beginning of the 1980s. But it was their times with the collection of the autologous bone marrow. It was not able nearly in more than 2/3 of the cases. It needs operation room, cumbersome, and it was also with very delayed engraftment rates. But after the introduction of the peripheral blood stem cell and peripheral blood cell collection by the groups in states, in the start of the 90s, the transplant rates exploded both for myeloma and then lymphoma. And if we look to our rate and to our data, this is nearly 6 years ago we shared, and that times we looked the activity according to age. And we have seen that beyond age 65, then we have some dropouts and high-risk patients. But in other patients, it was safe with nearly 95% of overall survival in 1 year. But if we look at our current data, nearly more than twice of the patients that we have in 2014, near 354 patients. And if you see that we have a median overall survival nearly exceeding 6.5 years. But the curve is classical myeloma curve. Myeloma is an incurable disease, and the autologous transplant with high-dose chemotherapy is not a curative approach, a overall survival extending approach. And this is clearly seen in our 10 years data. And if we look to our mean age, you will see it's around 55s. We have a few amyloidosis patients, second transplant, only in 7% of them. We are almost always using high-dose melphalan, and in mobilization, as you see, we were able to collect in 80% of the transplant candidates with only GCSF enough stem cells, even for double transplant. We have used chemomobilization in the remaining 50%, and then plerixafor based in 5% of the cases. And if we look to the impact of the age, I have shown you in your previous slides that we have seen some tendency over the age of 65 in myeloma patients. That's not the now with the growing experience and growing number. We have now doubled the size, and as you see, for 2 or 3 years, the curves are nearly identical. And if we look to the overall survival, then it's 65 to 77 months, which means there is only 1 year, but this is not statistically significant, which means now over the age 65, we feel safe, and we are not looking to the categorical age, we are looking to the biological age, which means for 75, we can still think both for autologous and allogeneic transplants. And if we look to the states data, we see nearly the same curves for plasma cell disorders. And as you see, time by time, they are improving as well. With new agents, with growing experience, is also concordant with our data. If we come to lymphoma patients and autologous stem cell transplant experience, then we see that in our series of more than 210 patients in Hodgkin's disease, we still did not reach the median survival nearly 10 years. And it looks like not curative. We have some late relapses, but still over 80% for this, as you know, second line use of high-dose chemotherapy, still impressive. In non-Hodgkin's lymphoma, the curve is now nearly identical to the 50%, and which is acceptable, but this is a very heterogeneous group, both including follicular lymphoma patients, mantle cell first line upfront, and some ALK-negative anaplastic large cells, PTCLs, and like this T-cell lymphomas as well. If you look data for Hodgkin's disease, you know, for chemosensitive, nearly 90%, and from chemoresistance patients, this is reaching 75%. The states data still says it's effective, and we are still looking forward in such patients. And if we look to the survival after autologous, we still see there is an improvement, not due to autologous transplant, I think due to use of now some maintenance with anti-CD30, and then the more reliable agents that we have in hand, like nivolumab, the other oncoimmunotherapies. And is there any impact of age in lymphoma patients? Now we have actually chose as a dichotomized the value to 60, not 65, as in myeloma patients. And as we see, still there is a significance. We should be careful, especially in patients over the age 60, if we are going to transplant them. In Hodgkin's, I will say, I want to, or I will be very selective. In non-Hodgkin's, if it's still recessive, refractory, and you don't have access to CAR T cells, then it's acceptable. What about the growing population of elderly? As you see, the trend to have more patients over the age 70 is increasing nearly since 2009. There are recommendations, there are papers. There are now geriatric hematological, geriatric transplant groups who are publicizing very much, but we should be still very aware of geriatric oncologists and geriatric hematologists, that we should be careful about the status of the patients, about the comorbidity of the patients, about the activities of daily life of the patients, to see that the patients over the 70 years are transplantable doesn't mean that we have to transplant all the patients. We should be careful about biology and then the definition of the daily activity living and the performance status. And the most important, the comorbidities of the elderly, which is oftenly overseen. And if we look to our data now, selectivity to diffuse large B-cell lymphoma, a very identical, and actually a little bit for me, I've recently done this analysis, and you see they are nearly curved. Then after 5 years, there is no drop. And it looks like the half of the patients in the diffuse large cell lymphoma group, they are profiting very well. But for the other 50%, we have to find some new agents like CAR T cell. In chemosensitive, we have better. In chemoresistant, as you see, less response. And our experience is not so dramatically better, but as you see, in the last 10 years, the 6 years, there is an improvement, but I think this is not due to autologous, maybe due to use of, after autologous failure, use of CAR T cells. And if we look to mantle cell lymphoma, as you know, currently still in mantle cell lymphoma, in not smoldering ones, but active chemotherapy ones, we are using Nordic-like, both containing cytarabine and anthracycline-based alternating regimen. And then after achieving at least a PR or CR, we are still upfront transplanting the patients with high-dose chemotherapy with beam, and then followed by 2 years of rituximab. And as you see, in mantle cell lymphoma, we are still like diffuse large B-cell lymphoma. With the introduction of rituximab, some improvement, but we need still more active surveillance. And mantle cell lymphoma progress after introduction of the maintenance is improved, that's clear, but we have still place to improve. And in chemosensitive follicular lymphomas, you see there is no such an progressive improvement. And if we come our COVID-19 era, first of all, I wish that all yourself as a health worker, your team, your family, your beloveds are on the safe side. We should be very careful, not only in the hospital, at home, with our beloved beings, that we have to prevent any COVID-19, both for all the population that we are confronting. In autologous setting, in the first one, I'm sorry that's in Turkish, but I will do this in basic ways. We should be careful. We are not suggesting as Turkish physicians and like EBMT and likes ASBMT in low-risk AML patients, which can go on without transplants, in MRD negative patients, which do not have the necessity of an urgent transplant, and then in low-grade lymphomas, and especially in myelomas, we are now postponing the autologous transplants. We are still collecting. We are trying to use mainly the GCSF mobilization, and we are actually avoiding chemo-based mobilization. Maybe use of plerixafor will be more intended. In lymphoma patients, if it's an aggressive one, if we need an urgent one, it's a necessity. If not, then we are collecting the stem cells and putting them to maintenance treatment. The most important thing is your team, because you have still many transplanted patients that they are on the early transplant period, which is vulnerable to all the COVID-19 related complications. We have shared all of our data with EBMT, and we are also able to have a place in the first EBMT COVID-19 cases publication, and the data is still in progress, but it's sure that the transplanted patients are hampered by COVID-19. There is a high morbidity and mortality. Both inpatient, pre-transplant, post-transplant, early period is very, very suspicious, and we should be on a very careful surveillance of COVID-19. For these reasons, every center should have their emergency plan. All the transplanted patients should be very wisely and clearly informed that they are transplanted in COVID-19 era. Not only your center, your hospital has to be established COVID-19 guidelines that should be frequently improved and revised. And we have to follow all the webinars and the necessary issues about the current recommendations. After discharge of the patients, both the donors, the patients, caregivers should be careful about any COVID-19 occurrence. And all the centers should be very sensitive on this issue. And if you like any recommendations, guidelines, both are national and on international level, EBMT, BMDA for the donors, and the WBMT and the British ones and the Europeans one and states have guidelines which are frequently revised. Please follow them. And if you come at the end of the presentation, where we are and what's our current progress in autologous. Now, we are located in our new building, newest building of the Florence Nightingale Group Hospitals, which is active since 2013. We are active on the 4th floor, and then we are getting our stem cells, and the other lab is in -2. And if we look to our floor, you see 16 beds. These are positively ventilated, HEPA filtered with double locked doors. And if you look at our transplant rates, they are around 120 to 140 per year, and nearly more than our allogenic by the rule. This is not our choice, but we are both active and powerful using allo and autologous. If we look, as you know, what's the place of a transplant center, which is called benchmarking of a center. And very recently, EBMT has a great effort on this issue. For the first time, they are publicized in 2019, and they have shown us in autologous and in allo CIP and match-unrelated donor setting in different disease entities, what should be the definition of success among nearly 200 centers which are actively participating. I will show you now a comparison, not only non-relapse mortality and overall survival. And as you see in autologous setting, if you look year by year or in myeloma disease specific, our results are nearly identical to EBMT publication. Our mortality in day 100 is less than 100, and our overall survival rate is more than 94% in myeloma. If we look to lymphomas, you will see our results are nearly exactly the same, both in EBMT and by us. By us, the day 30 mortality is less than 1%, and day 100 is 3%. And in EBMT, this is exactly the same. If you look to non-Hodgkin's and Hodgkin's disease, they are exactly the same numbers. Even our non-Hodgkin's are better performing. And if we look to a 2015 benchmark analysis among transplant centers in Turkey, and we are actually with first year of autologous with 90% more than transplanted patients among 50 centers. And if you look to our day 100 mortality, we have a 95% on benchmarking within the first 5 place in Turkish centers. And this is correlated with our publications, which means we are sharing our data with EBMT, with Turkish centers, and we are getting cited, and also we are publicizing nearly in participating in 10 years of the EBMT, both in allo and auto setting. And then this is also get commercial interest in the foreign centers, and then they are referring us year by year more patients, both for autologous and allogenic ones. And I'm very grateful that you are listening to me on this webinar, which is held for the auspices of the Group Florence Nightingale Hospitals. Myself, Dr. Özçelik, and then Dr. Görenşahin and our team are always welcome to all the questions and the comments that you may have. Thanks for listening. Now you can send your questions on the chat, maybe on Russian, if you like in Turkish or in English, and I will be happy to answer them.
Сейчас пересмотрю, что вы делали тогда. А вот я вижу это МРТ, то, что вы делали. Вот на КД практически змеи головного мозга. То есть ничего такого страшного там не нашли. У вас давление скачет? Постоянно сейчас я буду записывать, давайте, чтобы вы понимали. Рамизес, да? Рамизес ты только утром.
In 2000, yes, this is a question from Vasily Po. How many transplants that we will perform in 2000? My answer will be the transplant period is hampered by 2 issues. We have still transplanted more than 85 patients in 2020. But first of all, for COVID-19, we have nearly halved our transplant activity and postponed all myeloma patients. And the second issue is that we have moved from our old building due to a security problem with the building to our new that I recently depicted in the pictures. So according to this, there is less transplants, I think, in the COVID-19, still acceptable. We are still active transplanting, but we are avoiding the so-called low rate of myelomas and low-grade lymphomas, and we are expecting to finish the year with a 90 to 95 transplants. And then coming to second question by Türkan Kasimova. She thanks for the presentation. That's our pleasure that they are listening. And about the multiple sclerosis, thank you very much for this question, because it's actually a rare indication by us in Turkey. It's very strict policy. You should have received at least 3 lines of immunotherapy. If you fail them, and if you are in an immunoactive disease point, then you are allowed to go on with multiple sclerosis. But this patient population should be handled very wisely. First of all, this is a population which is hampered by the devastating multiple sclerosis neurological problems, especially urinary incontinence, infections, the not chemotherapy-based, but immunotherapy-based immune compromisation makes this patient population very vulnerable both for high-dose cyclophosphamide during chemo mobilization, because they should be mobilized with chemo. If you do this with only G-CSF, there is a risk that the multiple sclerosis will have an activation. We almost always do this with cyclophosphamide-based 2 to 3 milligrams per grams per square meter, and then with dexamethasone prophylaxis on G-CSF. After collection, you should be very careful again about gastrointestinal system complications and urinary sepsis. But in our 4 cases, we were able to complete the transplant with close collaboration with the neurologists. And we think in selected cases in a safe, but you should be careful both on mobilization and with the regimen. The regimen that they are currently using is Rapid ATG plus Beam. And this is the European recommendation. If you are interested in multiple sclerosis and autologous stem cell transplant rescued high-dose immunotherapy, I can refer you to the recent publications by the EBMT Autoimmune Disease Working Group recommendations and the series of cases, not only for multiple sclerosis, for the other ones like systemic sclerosis and rheumatoid arthritis. And the third question by Pavel Trachtman, thank you very much again. Have you faced in the recent transplant patients? Unfortunately, yes. In patients, a few on the outpatient. Now there are numerous. It's changing actually. We have seen very complicated ones after first or second year of transplant. It's the not up to the transplant. Almost always very powerful in allo transplant recipients. I don't have to underline, but the issue is with use of the steroids and the patient's immune status. If the patient is in a chronic GVHD, still on immunosuppressive agents like corticosteroids, etc., though it's always called that the corticosteroids, especially dexamethasone, is protective and maybe improving the results in COVID-19, they are immune compromised. And I think they are causing both mortality and morbidity. We still use the same, and we always underline the first thing is prevention. If you got the disease, we are trying not to hospitalize and then to make them safe at home if it's possible. If they have these symptoms, and not only the symptoms, the respiratory dysfunction, they have to be hospitalized. And unfortunately, the outcome is dismal. Please feel free that you can ask and raise any question in Russian or in Turkish or in English as you like. I will be happy to answer and to share our experience. The main target and main aim of this webinar is actually having not face-to-face, but a direct platform that we can connect and communicate with each other. Please feel free. I'm happy to answer. And coming to question in COVID-19, it was also a major problem, not only in Turkish patients. We have many foreign patients. I mentioned in my slides that they are transplanted at day 100. They have to go back. In their countries, which very much faced with COVID-19. A few of them, unfortunately, encountered COVID-19, get COVID-19, and we have lost such patients. Now we are trying to inform all the patients about this issue, that they have be very careful in their home country for COVID-19. This is now a pandemic, and we should be very careful in allogenic and autologous transplant recipients. I think Alexander. The second question by Turkan Kasimova is on the treatment and handling of myeloid sarcoma patients in COVID-19. I will a little bit extend this issue: acute myeloblastic leukemias, sarcomas, and then aggressive lymphomas. In this setting, unfortunately, the hematologist has not the power anything to postpone. These are urgent indications, and they have to be treated properly. We cannot say in AML patients with intermediate and high-risk features, especially in younger ones, okay, get the decitabine for 5 days outpatient, and then get the venetoclax for 14 days, and then we look because we have COVID. This is impossible. Because of the reason they are getting what they are actually requiring. But especially in low risk patients, we are careful. And then we are trying to prevent the prolonged hospitalizations in COVID-19. We are, after introducing the therapy, we are discharging them as soon as possible. And we are trying that they are safe at home and they have less hospital visits. We are trying to follow them online, and we are communicating them online. We are now, after transplant controls are now less frequent, we are doing this on online basis. And if the patient has something that requires face-to-face or maybe hospitalization, like a new GVHD or like this, then they are visiting the hospital. In acute myeloblastic leukemia, you can extend the periods if the patient is MRD negative, low or intermediate risk. In high-risk ELN score patients, and if MRD positive, you don't have this privilege to prolong or to prevent anything. You should do what's necessary. I think Alexander Petrusha has a question. He raised his hand. But his microphone is muted, actually. Like I said, please feel free. This is an open platform that you can not only transplant or autologous related, you can raise your questions for any hematological problem you are confronting just now. I'm not only a transplanter, I'm also the consultant hematologist of our groups. And so I will be happy to answer. Okay, that's a very good question from Vasily Pop. Does the insurance cover the additional costs associated with COVID-19 therapy? There are two facets for these questions. First of all, our national insurance is nearly one of the top covering insurance system, which nearly capacitating 98% of the population. As this is a pandemic, our government has elucidated that many hospitals, even the private chains, are now pandemic hospitals, and they will hospitalize every patient who are referred, which means the costs will be covered by the government, not on a private insurance level, but a classical governmental insurance level. This was not only for the hospitalization, by us, our guidelines is always privatize the use of first azithromycin and then the quinidine and then the favipiravir. Currently, it's changed. Now we are only using favipiravir with an additional use of heparins for the risk of any thrombotic events, which is very important. And all these costs and all these medications are provided by our government. The private insurance company is covering the additional costs. They have also elucidated this issue. I think any Turkish citizen, even the migrants, are covered in this pandemic era, which we actually grateful for our government, for our health professionals, and for our Ministry of Health. We are actually following the guidelines provided by the Ministry of Health very frequently. But this is very important. We are now listening from many countries that it's not covered by their governments, and they have lack of manpower, lack of medications, and lack of hospital beds. Turkey has managed also the hospitalization issue quite well with the so-called state hospitals and all the chains available in Turkey, both private, universities, foundation hospitals. They have done their best to support all the COVID-19 cases. Now we are on the merge of a second wave, which looks like more powerful than the ever, and we are trying still the same. But I will say we are getting exhausted. Another issue is COVID-19 is, I think, now the coming influenza season. I will say that you should immunize all your hematological malignant patients, both for pneumococcal vaccine. It can be a 13 or it can be a 23, polyvalent or polysaccharide, but you have to get actively immunized. The second is the coming influenza agent and the necessity for influenza shots. That's also the flu shots are a necessity, and it should be done before December. Now we are trying to immunize all of our patients actively. Only you have to be careful that after an autologous, maybe after 3 months, in allo after 3rd or 6 months, you can start without using the live vaccines, the vaccination protocols. And if you have a patient in early period, you can use safely. We have this experience, convalescent plasma. But as early as possible in high-risk patients, if the patient is now in an ICU, has a respiratory problems. Unfortunately, the convalescent plasma is not working. So because of this, now we have changed our policy on a national basis that we are using convalescent plasma early in high-risk featured COVID-19 cases. Use of hyperimmunoglobulins, the so-called cocktails, monoclonal antibodies, and mesenchymal states is stem cells, also the tertiary available treatment options, but unfortunately they do not still show the efficacy enough. And COVID to COVID-19, now I think everyone is now a bit excited about the upcoming vaccines. What should we do? How will we do? Now we will do this. Actually, as you know, there is a Prioritation Protocol which is published in JAMA. I can refer you very recently. There's also some discussion on this issue, who should be and how to be immunized if they will be available. As you will imagine, after health care workers, our transplanted patients, our compromised patients should be on the first line to get the vaccination. That's for utmost importance. The issue with COVID-19 seropositivity is another discussion. We have to check them before and after the use of immunization. That's a rule. And then the third question from Turkan. Thank you very much. Turkan is a very active. There is an M3 patient, just diagnosed, untreated, but it's COVID-19 positive. And now we are trying to use an anticoagulation. And how? Oh, that's a tough question, Turkan. First of all, if this is an M3 patient, you have to start as soon as possible with all-trans-retinoic acid. That's a mandation. If you have any, not the diagnosis, any clue or any question about the possibility, a provisional diagnosis of M3, you should start as soon as possible with ATRA. It's life ensuring. Then, because ATRA will also lessen the procoagulative and unfortunately the bleeding problems, especially the intracranial bleeding. The COVID-19 positivity, there are two positivities. First, this is a COVID-19 disease, and this is PCR positivity. I will still go on with ATRA. Maybe I will avoid idarubicin, and then I will follow the patient. If you have an approach, and if this is an intermediate or high-risk patient, in even low-risk patient, you can use first line, some second-line agents as well. These are more probative. For the use of anticoagulation, I will do this on patient-by-patient disease. Why? Because if you have a patient with low platelets, high white blood cells, which means high risk, and then coagulopathy, you can't use any kind of coagulation. You can use only compressive bandages for the legs. But if there is no sign of them, then you can use, if the platelets are okay, and you have enough platelets, which may be not the case in M3, the classical, till the platelets are lower. And there is another question from Tamira Azagui. Thank you very much, Tamira. This is for mantle cell lymphoma, plasmacytoma-like patient. And the question is, which treatment is more suitable? A chemo or radiation? If this is a plasmacytoid mantle cell lymphoma, it's up to the disease. It's a local or is it disseminated disease? I understand if this is local, I can go on with radiation. No, never in a mantle cell lymphoma patient with plasmacytoid features. I won't do this. I will go for chemotherapy. Then after chemotherapy, you check. And then if you see any sign, it's a PR and then PET activity, maybe you can use radiation. Mantle cell lymphomas are still radiosensitive. And which will be the treatment more suitable? That's a good question. I think there are some protocols that are using Velcade proteasome inhibitor like induction regimen, which we are using actually as second line. Maybe this, but this is not actually shown in any randomized study that in plasmacytoid features of mantle cell lymphoma, such Velcade or proteasome inhibitor containing induction regimens are better. I will go at least for classical, alternating both using cytarabine and R-CHOP-like, and then check with PET-CT. According to the response, I will go forward. But if you need more advice, please do not hesitate to send all the PET and related, especially the pathology report. Then I can go on according to age, to comorbidities and the condition, more advice. I will be happy. I see that from Alexander and then from Petrusha and from Zomart Agazadeh. They raised their hands. We are waiting for their questions.
No questions, thank you.
No questions. Okay, thank you for listening. And Zomart, do you have any question? You have raised your hand. Okay, let me explain a few issues how now situation in Turkey is. I mentioned the COVID-19, the second wave. Now we are lessened our autologous activity as well. We have stopped our autologous activity on myelomas. Actually, we have stopped this at the first wave. Then under some improving conditions, we have performed all of them. And now we are collecting the stem cells, cryopreserving them, and we are trying to use only G-CSF, as I mentioned. In the setting of the aggressive lymphomas, we are trying to postpone, but we are collecting the stem cells. In the setting of the myeloma, we are trying to give more or less oral agents for supplementary use of bone protective agents like zoledronic acid. We are doing them now every 6 months, not every month or every 3rd month. And for rituximab maintenance patients, we are trying to avoid them. And then we are doing them every 3 or 4 months, not every 2nd month. And if this is a COVID-19 patient and using some agents like favipiravir or others, we should be very careful for the use of them with the other chemotherapy or actually our prophylactic agents, because there's a drug interaction and we should be careful about our hepatic microsomal activation. In the other issue is we have a COVID-19 case, now looks fine and had the disease 3 or 6 months ago. One of the patients which is encountered in the first phase. If the patient is a transplant candidate, both auto and allo, or this is a chemotherapy candidate, what should we do? Actually, we are trying at least to have passed 3 months after the chemotherapy, after the infection. We check the patient, we check the chest CT, and then if there is no sign, we look to the antibodies. But if the antibody is too high or IgG level is low, this is not an indication that we can do or not the transplant or the necessary treatment. This is only for academical purposes. But if the patient is still IgM positive and less IgG, which means prolonged disease or the so-called late wash-up period for the PCR and antibody positivity, then we should be careful in this population. They can have flares of COVID-19. We have seen such cases both in transplant and non-transplant setting. I will urge that you wait, watch, and see what's going on. Don't go ahead with an chemo or transplant in such gray zone COVID-19 survivors. One of the issues with COVID-19 is not about the early, the intermediate, and the late effects. And this is like brain fog or cardiac morbidity and mortality, psychological issues, and all the other. The most is first the cardiovascular, and the second is the neurological issues, both on cognition pattern. This is very important because we still don't enough clues and explanations for the pathophysiology of COVID-19 and the virus, the novel virus of corona. So we have to wait and look for the publications. Unfortunately, the publications, nearly half of them has only data, no straightforward clues. Please careful on reading and interpreting. And the otherwise are sometimes really suffering from less data and less clue. Actually, they are not evidence-based. In COVID-19, all the physicians are suffering from evidence-based medicine approach. Now it's time to use our instincts, our courage-based knowledge, both for the use and passive and active immunization. This is the first pandemic that the world is encountering nearly after a century. And actually, as we are the physicians, the governments are not well prepared, like in the start of the 20th century. That's for true. We should be careful. I think we should come to an end after a full of 1 hour. I'm glad that you managed to listen to me, to our webinar on the auspices of Group Florence Nightingale Hospitals. As you know, this was the second in the row and will be followed with the allogenic transplants by myself again. We have started with renal transplants with our nephrology and the renal transplant team, and mine will be followed by our very distinguished liver transplant team. As a comprehensive transplant center, Group Florence Nightingale Hospitals, nearly since the start of the 2000s, active in transplant, and now with their experience, with their experienced hands, with the number of transplanted patients, both on not only stem cell transplants in hematopoietic setting, in liver and renal transplant, we are in close collaboration and we are also collaborating against COVID-19. This is not only a problem of hematologists, this is a problem all transplant physicians. I should underline that the transplant recipients, especially solid organ transplants, are at high risk. Thank you again for your presence. I wish you a safe for you, your family, your blood banks at home, at your country, for your citizens. And the second, at hospital, for you, your physicians, all the health and health associates and your patients, safe, COVID-free, or maybe COVID positive without any side effects, safe life. Thank you very much.